All right. So, good morning and greetings from Indian Association of Gastrointestinal Endosurgeons. Uh, Today, we'll be discussing a very important topic, oncology in COVID pandemic. And so I'll just share the screen first. Yeah, so oncology in COVID pandemic and greetings from the IAGES. So today we would be discussing about practice of oncology. Has that changed during the COVID times or is it the same? And we'll take into perspective the patient as well as the healthcare worker who's at risk as well. And to discuss that, we have an excellent panel today with us. Uh, Dr. Ajay Kriplani, he's director and head of Minimal Access Bariatric and GI at the Fortis Gurgaon Hospital, and he is the past president of IAGES as well as an advisor at the IAGES. Then we have Dr. John Thana Kumar, a senior surgical gastroenterologist practicing in Coimbatore. He's also the past president of IAGES and an advisor at IAGES. Then we have Dr. Rajesh Bhojwani. He's chief of surgical gastroenterology at the Santokba Durlabji Hospital. He's also the EC member of IAGES. We have Dr. Selva Sekhar, who's joined us from the UK. It's 6 in the morning for him. So welcome, Dr. Selva Sekhar. He is consultant general colorectal laparoscopic and robotic surgeon. He's director of surgery at the Christie NHS Foundation Trust, Manchester, UK, and also the honorary senior lecturer at the University of Manchester, UK. Then we have Dr. Anil Arur. He is the chief and head of surgical oncology at the Fortis Mulund Hospital in Mumbai. And then we have Dr. Soviraj John, who's a senior consultant of minimal access, bariatric, GI, and robotic surgery at Sir Gangaram Hospital. And he's also an EC member of IAGES. Welcome, friends. And let's go down to the oncology in COVID pandemic, and we'll take your views. We'll divide the presentation into three components. The first component would be the general principles of surgery and oncology during the COVID pandemic. The second would be the organ-specific management of these cases, and the third would be conclusions and take-home messages for all the people who are watching and all around the country and across the world. So. Rationing of services is extremely important during this COVID pandemic. All elective surgical and endoscopic cases should ideally be postponed at this current time. This is according to the SAGES and EAES recommendations, and they're by and large similar to almost all the recommendations all across the world. Surgical care of patients should be limited to those who need who have an imminent life-threatening problem, and therefore a surgical care needs to be offered. These may include patients with malignancy that would further progress or with active symptoms that require urgent care. All others ideally should be delayed until after the peak of the pandemic is seen. Procedural considerations, there is very little evidence to suggest that whether minimal invasive surgery is good or the conventional open as compared to the safety of the procedure for the patient as well as for the healthcare workers. Strongly recommended by SAGES that consideration be given possibility of the viral contamination to the staff. So due care needs to be taken whether you're doing open, laparoscopic, or robotic, and protective measures are strictly employed for the OR staff safety and to maintain a functioning workforce. Now, this is what the SAGES said for almost all surgical procedures. Oncology, malignancy could be completely different. They may say that minimally invasive surgery can be done, but we are going to discuss whether ideally it should be done or an open surgical procedure is a better choice procedures, particularly when we are dealing with malignancies. We'll discuss that. So masks are a must. So I just copied these guidelines to the Ministry of Health and Family Welfare. They are slightly different than what is being practiced abroad. Here they are quite stringent. They say you need to wear an N95 mask at all places except when there is a visitor attending the OPD or a visitor accompanying patients in the IP facility. where he can wear a triple layered mask. By and large, apart from that, N95 masks everywhere, gloves everywhere. And then if you're looking at ICU facility or any of these high risk areas, then of course you need to wear a PPE. This is the recommendation by the Ministry of Health and Family Welfare. Coming to the filtration in the OR, we'll take your opinions. Intraoperatively, filters are important. HEPA filters, by and large, would be there in all corporate hospitals, which have a minimum 99.9%, 997% efficiency and can filter up to 0.3 micron in diameter. But when we go to the ULPA filters, which can actually filter up to 99.99% of the airborne particles and going down to 0.05 microns, these may not be available at most of the hospitals. So what we have is, by and large, the HEPA filters. Again, general recommendations, electrosurgery units should be set to a lowest possible setting. You can use all three of them. Generally, again, the recommendations is the ultrasonic produces the particle size, the aerosolization is slightly bigger. So therefore, the chances of contamination is a lot less. If you're using a monopolar diathermy pencils, attach a smoke evacuator to it. Now, this is where we have a problem, particularly when we are doing laparoscopic procedures. Carbon dioxide insufflation pressure should be kept to minimum. Yes, we can do it to 12 millimeters, but ultrafiltration smoke evacuation system of filtration should be used. That's a recommendation by and large by all societies. But do we have it in our country? That's a big question mark. All pneumoperitoneum should be safely evacuated via the filtration system before the closure. Trocar removal, specimen extraction or conversion to open should be after all the filtration has been done. The abdomen has been completely deflated. Hand ports should not be used. So this is a slide which was sent by Dr. Selva Sekhar, that absence of evidence is not the same as evidence of absence. Therefore, suggesting that MAS may have benefits, but there are potential risks to the healthcare environment, particularly to the staff. So these are the filtering systems which probably would not be available in most hospitals in our country, in our system. And therefore, we need to question prolonged surgery in malignancies. We do not have these filtering system to actually, filter the CO2, desufflating the abdomen. So do we actually need to do minimally invasive surgeries, or do we actually opt for doing a quick open surgical procedures, particularly for malignancies? Intubation, yes, it's important. I would call upon Dr. John Thanakumar. He's devised an innovative method for intubation. Dr. John, please.
Randeep, thank you very much for arranging this excellent panel discussion by IAGES. Not only you, but also the President, Secretary, and all the EC members for taking the initiative in a very nice and important way. First of all, I want to correct you a little bit. This is not mine in the sense I'm helping to do this. A company was already doing it. So what I showed you was the initial setup here. We know that most of the procedures, we know when we are intubating the patient, sometimes they cough, or during extubation they cough. There is aerosol formation, aerosolization. I bet that's a new word. This comes up, and unfortunately it comes up straight to the anesthetist's face, or the nurse who's near the patient, or the anesthetic technician. So this is just an acrylic kind of box with two holes on top so that the tubes go in. And now we have sort of modified. Can you come on the camera for a minute? What I showed you is a prototype which we did for our initial case. And here we have the actual one, which I am still tried. I'm waiting for the next case to try it on. It doesn't matter. You can see the nurse inside lying down with my hands as the intubation, for intubating, practically ready to intubate. So it's not difficult to do. There are some restrictions. You wouldn't be able to do it very clearly as you would in a standard procedure, but it's a lot better than putting a bucket on your head and few other things which you have. Now, this doesn't cost much. actual cost they told me was 3,500 rupees. But they are also in the process of incorporating a suction device here, along with the ultraviolet radiation. You know, the one of the theories is ultrasound also can kill the virus. We don't know how efficacious it's going to be, but it's been quoted. So we wanted the ultraviolet radiation incorporated in this. That's what they're doing now, and it's still in evolution. I'm sure, you know, there'll be other models coming through. I've already seen in the net other people doing it as well. As I said, I'm only giving the ideas. It's being done by the company, and hopefully this will be very useful to people, the anesthetists and the others. Generally, it is mentioned you have to wait for an hour after intubation. It's got to be done in a separate area where there's negative pressure. All these are not possible. We don't go by the clock. We have to sometimes, very often, enter early. These are all negative things. But so this aerolization will decrease, if not abolish, the aerolization. Thank you.
You can go on. Endoscopy. This is the PPE that you're doing an endoscopy. So just to mention the protection here that you're taking, particularly when we know there's going to be a lot of aerosolization during endoscopy.
Yes, in some of the cancer surgery, you might be able to manage with a spinal or longer ones with an epidural anesthesia. By and large, most of the general surgery with oncology, like say for instance the breast or anything higher up, upper abdominal, one will have to give a general anesthesia. And before that, we try to avoid surgery in many of the cases as far as possible. All patients require treatment, not only the early cases who will have surgery in COVID times, but also the advanced cases in COVID times, especially according to one of the guidelines. If you think by doing this procedure, your patient can live pain-free for about a year or so, it's worthwhile doing it. So this may involve things like intubation of esophageal tumor, or for instance, I don't want to step into somebody else's topic here, but you know, if you have a CA pancreas needs intubation of the duct. So these are all procedures in which you do an endoscopy. Endoscopy, I'm not talking about the diagnostic endoscopy. This is a borrowed slide from Dr. Govindaraj, who is one of our very able, formerly EC members, now the Vice President of the South Zone. He's a very accomplished endoscopic surgeon, and he has got it here in this hospital. This he does it on chosen cases. He's intubating a CBD here for an obstructive jaundice with cholangitis in a patient who did not respond very well to antibiotics. So well chosen case. While doing the endoscopic procedure, a lot of spillage comes to you onto your face. So here, notice this is practically theater where everybody has got a PPE drapes and N95 mask. And this is the kind of setup you need to have, this like a regular standard operating procedure. So this is something I borrowed from him just to talk about. Thank you. Over to you.
Yeah. So this is the surgical triad which has been recommended by the IAGES that if there's a patient, this is not just specific for malignancies, but for all. This is just a surgical triad. If a life-threatening surgical emergency comes in, yes, you require to do a surgery wearing all those PPE and the equipment which has already been shown. If not, then if surgery is put off for 3 months, will it impact the survival? That's a question. That's where the malignancy comes in. That's where the cancers come in. If yes, it generally will impact the survival, then you should offer the surgery. If not, then the next question is that would it significantly affect the quality of life, pain, sepsis, complications, immobility? No, then delay the surgery. Yes, then the question needs to be asked is whether there's a viable alternative. If there is, again, delay the surgery. If not, then go in for a surgical procedure. These are the intercollegiate surgery guidance guidelines. Dr. Selva Sekar, these have been sent by him. If you can go through these guidelines, please, and tell us what are these guidelines and how are you managing these patients in the UK? Dr. Selva Sekar, are you there with us?
Yes, yeah, I'm here. Sorry, I was on mute. So thank you very much, Randeep, and thanks for the IAGES for organizing this webinar. Basically, in UK, after the COVID pandemic started, the intercollegiate guidelines was released, which basically gave us a platform for us to use in managing patients who come in as an emergency or as an elective or for an elective procedure. Those who come in as an emergency, obviously we don't have much time to deal with the preparation, but we take every effort to make sure that they are COVID tested. And if it is positive, then we make sure that the surgical team, not just the surgeon, the surgical team has a full precautions. And also for consenting, patients are explained that there is a high risk of post-op complications and mortality. Patients who are having CT of the abdomen as a routine practice, now they have a CT of the chest to document if there's any typical features of COVID. During the planned, and for the surgery as such, in an emergency situation, if someone comes in with a large bowel obstruction, instead of going in and taking the tumor out, the recommendation is that you need to seriously think about stenting, anything to do a minimal procedure which will get over the crisis is the thinking behind this. And if the stenting is not possible, a stoma, and then look at reviewing the patient and also the cancer or the other pathologies which may be associated with it at a later date. What has come out, what is happening is patients who are having surgery are all put in a database, and that is under the COVID surge. And the preliminary results from the COVID surge suggest that patients who have surgery, when they develop coronavirus infection after surgery, have about 25% chance of mortality and about 60 to 70% chance of a chest infection, which can be pretty bad, and they are admitted to intensive care unit. So these are strong evidences coming out suggesting that surgery, because of its immunocompromised state in the immediate post-op period, exposes them to higher risk of COVID infection and also for other nosocomial infections. Patients who are planned for an elective surgery, they all have the COVID testing done, ideally within 48 hours. But at the Christie, we do it within 7 days because it is technically not feasible to get all these results back. We do the COVID testing, and we make sure that the results are back, and also get a chest X-ray within 24 hours. But the current thinking is that in the next few weeks, if the same system continues, the recommendation may be that they all should have a chest CT, which will have a huge implication on the resources and the way the theater functions on the day. And surgery-wise, the always recommended nowadays is a risk reduction strategy, which is to give a stoma and not work at doing an extended resection, mainly in colorectal surgery, which is my specialty. The days of coloanal anastomosis and things are all needs to be reviewed in the current climate. And regarding PPE, there are strict guidelines which have come up from the Public Health England, which suggests that all patients should be treated as COVID positive. Even though we do these COVID testing, they are not, they have got their own limitations. They're only about 70% sensitive. So we make sure that this theater staff have the full PPE during surgery. Theaters, minimal staffing. There's not much of a movement to reduce the footfall in theater. Stop the positive pressure ventilation. It is technically very difficult to do. At the same time, it exposes the patients to higher risk of surgical site infection. And extubation and intubation is done in theater rather than in the anesthetic room. And wherever possible, reduce the smoke or prevent aerosolization. Laparoscopy is done in a very limited way. As already Randeep has shown, we have insufflation device. We use the air seal where you can use a low pressure pneumoperitoneum, which is a continuous flow of carbon dioxide, and also use special plume ports to for during desufflation, which will absorb the carbon dioxide which are let out from the patient. There's no way we can just open these ports out, let the carbon dioxide out in the atmosphere. It is both for laparoscopy and for robotic surgery. Endoscopy is only done as an emergency. All elective endoscopies are cancelled at the moment. but there are plans to reinstate them. But obviously, with full PPE is the way it is being planned. Thank you very much.
Uh, so the SAGES and the ES recommendations are exactly the same, not much difference in the recommendations there. So now we can get some suggestions and statements from our the other panelists, starting with Dr. Rajesh. Anything to add here before we go on to the cancer-specific treatment?
Thank you, Dr. Randeep, and thank you for having me over. Thank you, IAGES, for having me over. I think I have something to add. We, of course, have the guidelines from the UK and, of course, from the SAGES, but I think we need to, and we also have the guidelines now from India, from all the three societies. But I think we need to put in perspective our own hospital settings and our own hospital environment, whether it's a COVID designated hospital or a COVID negative hospital at the moment, or a COVID segregated hospital. And based on the expertise and the experience, because cancer surgery is something which is we all know, by and large, all cancer surgeries, they have a better outcome in the high volume centers, cancer by cancer, and a higher morbidity is seen in low volume centers. So I think all of these factors have to be put in perspective, and then only decisions should be taken about whether to proceed with cancer, particular cancer, with surgery or not, or use other modalities. But I must make a statement here, which is, I tried to go through these SAGES guidelines. And somehow I tend to differ from what they have mentioned. I don't know why, but I feel SAGES stands badly confused. I mean, if you look at the previous slide, which you projected, SAGES at one point recommends laparoscopy, saying, there is little evidence of MIS risk specific to COVID-19. And there are proven benefits of reduced length of stay, and there is a device available to filter released carbon dioxide, and if you can minimize use of energy devices. But at the same time, SAGES also recommends that you should have dedicated ORs for COVID-19, and all patients should be tested, and consent should cover COVID-19. So I think, one has to be clear, the surgeon has to be clear in his own mind, whether he is looking at one side or the other side. Are we looking at the COVID risk or not looking at the COVID risk? To my mind, particularly when it comes to cancer surgery, and particularly when it comes to minimal access cancer surgery, there is no way you can perform a cancer surgery without the use of an energy device, particularly minimal access. And therefore, one has to keep lots of questions in mind. We don't have proper smoke evacuation systems in India. So I think a person will have to take his own judicious decision after due diligence in every single individual case.
Thank you, Rajesh. Dr. Kriplani, sir, please.
Indeed. But we have to remember lots of things. It is not so simple as these recommendations stand today. We have very little knowledge about the COVID-19 virus. We know this virus only for the last 3 months. Earlier than 3 months, we knew nothing about it. And even now, we know very little about this virus. We have very little experience overall patients to treat how COVID virus, and these recommendations that we might be discussing today might be correct only for today. As the experience gathers, as we see more patients, as we learn more about the coronavirus, these recommendations perhaps will change, and will change very rapidly. In treating these patients during the COVID time, we also have to see not only the viral factor, but the local economic, social factors. You see, we have to know that it is very simple to say that you postpone the patients of gallstone and treat them conservatively. But this is all presuming that this wave of coronavirus is going to subside in 2 months, 3 months, 4 months, which is only a presumption. We do not know how long these waves of coronavirus are going to last. We also do not know whether these waves will recur. And if they recur, then they'll recur with what intensity, with what volume, with what load. So all these presumptions, all these guidelines that we are making today presume that we are seeing this phenomena for 2 months, 3 months, 4 months. But if this continues for a year or a little more than that, which will be very unfortunate, then perhaps these guidelines have to be entirely changed. Also, what we have to remember is that, particularly coming about the malignancy patients, all these patients who have malignancy are generally in the elder age group, beyond 55, beyond 60. And these are the age group of patients which are more at risk of coronavirus, where the mortality is going to be higher. So we have to be very careful and very judicious to decide whether we treat these patients surgically or we take the help of neoadjuvant treatment. Similarly, also we have to see whether our hospital, our society, our patients, our neighborhood can afford this treatment, which are being the guidelines which are being forwarded by SAGES and the NHS, whether our patients can really afford it. The insurance will not pay because insurance are already creating packages. So it's a very complex phenomena. And at the same time, while we want to protect the interest of the patient by not increasing his risk, we also have to protect the interest of the healthcare workers, our team, because if our team gets infected or goes into quarantine, then as such, there is going to be a lot of shortage of healthcare workers, not only because of disease itself, but even the quarantine, doctors, nurses, orderlies, staff. So we have to see with what volume we should be doing these patients. And we also have to see whether if there's a high wave of coronavirus, then perhaps the priorities will change. If there's in an area, geographical area, where there's a low wave of coronavirus, where the disease is more contained, perhaps the recommendations will change. So these recommendations will not be uniform over a large geographical area or from same for all the countries, but even in a large country like India, it might differ from case to case. And if we have to decide whether we want to, if there is a geographical area with a high wave of coronavirus, do you want these patients to wait for surgery till the wave is subsided, or you want to see an outside geographical area where you can shift the patient so that he can get an adequate and proper treatment? Because it is very important, while protecting the interest of the healthcare workers, the patient should not feel that he is not getting the correct treatment, he is not getting the optimal treatment, and his treatment is not being compromised or marginalized. So it's a very tricky situation. Our recommendations are going to change perhaps every 4 weeks, every 6 weeks. As we learn more about the coronavirus, we will learn more about the natural course of the disease. As we learn more about the complications that happen, about how our paramedical staff or whatever hospitals, evolve during this phase. So it's a very complex procedure. And what we are discussing today should only be regarded as a beginning of the recommendation rather than the end of the recommendation.
Thank you, sir, and excellent points. So how long and do we actually need to treat these patients? Only hospitals in the green zones. Dr. Soviraj, anything to add here, please?
Thank you, Randeep, and thank you, IAGES, for this meaningful and I think timely webinar. I'd like to just highlight two issues, and that comes in the background that we're dealing actually with immediately, if not in the near future, a life-threatening disease. This is a different situation than benign diseases. So you really have to be on your game, on the top of your game to get this right. And in this, the two issues is, please take the comfort and the expertise of the MDT, the multidisciplinary team there, because that is going to customize it, especially to your local needs. And secondly, have a constant and intensive conversation with the family and the patient. This is an evolving situation, as highlighted by Dr. Kripalani and Dr. Rajesh. We don't know how things are going to be 2 to 3 months from now. Many of the patients in neoadjuvant therapies are going to come out into the surgical time period in a few weeks, a few months. So you really have to be in touch with your MDT and your team to get the best options. They may not be the classical options, but I think keep in constant touch with the team as well as the family to get the best outcomes. Thank you.
Thank you, John. Dr. Anil Arur, any comments, please, on this before we move on?
Thank you, Randeep, and thank you, IAGES, for this excellent and timely webinar. Malignancy definitely is something that is a conundrum, because the general guidelines may not apply to malignancy. This is an evolving phenomenon. Two suggestions that we have started practicing. One is regarding the anesthesia. During the anesthesia, I think that is the period where the maximum aerosolization takes place, as far as if you actually look at it, even more than laparoscopy, it is during the anesthesia times. So one of the changes that our anesthetist has done is to go back to the old method of using scoline, not really, use an atra and start ventilating the patient. But to put an oxygen mask, use choline, and then go for intubation so that the patient does not bug, patient does not exhale, and thereby reduce aerosolization. Secondly, no member of the operating team goes in unless the patient is intubated and the endotracheal bulb is inflated. So these are small changes that occur. As Subiraj said, the MDT team becomes more and more important. Your volumes at your center, the kind of protocols that you have set and followed for so long have to be embellished, because that is the way we are going to tackle these patients. Guidelines are going to give you the general philosophy of treatment, but obviously we need to modify, and we need to use our common sense to implement them. I think one also needs to look at SSO guidelines, which talk about the green zone, red zone kind of segregation of patients. They say that if you are in the pre-surge, you can go ahead with routine surgery provided you follow protocols. And I think this is where most implementation of the guidelines will come in. We have to modify it to our scenario. Consenting of the patient is something that is important, and that is where I think we have to talk about alternative therapies. We have to talk about higher risk of surgery while operating during the COVID pandemic. And thirdly, the possibility of the patient getting infected with corona during the treatment, because there was one case in Mumbai where the patient accused the surgeon of being the cause of the corona transmission. So that is something that we have to be very careful about, and we have to look at consents differently than we do in normal times. Thank you.
Thank you all the panelists for excellent comments. There's a comment which has come from Dr. Jinesh Doshi, and he mentions that smoke evacuators are cheaper than a ventilator, so we'll have to buy them and make things safer. I quite agree with him, because like Dr. Kriplani said, COVID is not going anywhere. We are going to live with this phenomena or this virus. So then maybe these smoke evacuators, probably if one is to attempt minimal access surgery, then these probably would need to be made available to our patients, particularly in all the corporate hospitals and even the tier 2, tier 3 cities. So coming to cancer care, Dr. Subiraj has mentioned already that multidisciplinary team meetings are extremely important. They can be held virtually as far as possible. The core team needs to be there, so the decision is a cumulative decision, and then the best decision comes out, and then MDT is responsible for the decision, classifying the patient's priority level and the need for a surgical procedure. So MDTs are extremely important. Shilsky, who's a chief medical officer of the American Society of Clinical Oncology, and this is what he published in the Lancet, that on the one hand, a patient might be at a high risk of contracting infection because he's immunocompromised, or he's already received a neoadjuvant chemotherapy waiting for a surgery and he's dying from it. On the other hand, the patient might be at high risk of cancer progression because of it causing death if it is not treated appropriately. So we are in between the devil and the deep blue sea, and need to find out the right reason and the right treatment at the right time. Essential points again have been mentioned by the panelists, that the treatment should take into cognizance the fact, the comorbidities of the person, the age of the patient are paramount in assessing the relative risks and exposing the patient to coronavirus, pursuing alternative and next best options such as neoadjuvant therapy as against a surgical procedures. Resources are again important, whether you're being treated at a corporate hospitals, your tier 2 cities, and so on, and then see the surgeon and the hospital and then decide the treatment. So what we are going to do is the phases are already defined or designed by various associations. So we are going to stick ourselves to the unaffected or the semi-urgent, where the COVID-19 patients may be in the hospital or may not be in the hospital, but the resources and ICU beds or ventilators are not threatened as of now. That's where we are, because in India we have designated COVID hospitals. We are not treating anything else except COVID patients. So we are not taking the urgent 3 or the emergent situations wherein these patients would not go to those hospitals, would be confined to probably a 1 category semi-urgent kind, where there may be a few patients, but at the same time, resources and ICU beds and ventilators are not threatened, and the patients can be treated. Starting with cancer breast, this is a patient. This is a slide sent by Dr. John. Dr. John, please.
I also wanted to say these patients have a, I also wanted to say that these cancer patients who are under treatment with or without surgery, it's very important that they can pick up infections which can be very grossly, it can kill some of them, many of them, if they get infected. And so there should be a minimal hospital stay. That's something very important. So if you normally discharge a patient after about 10 days, you try to get the patient away in 2 or 3 days if possible. So that's something to add. Now, generally, in oncology, if the tumor is early, we tend to operate and get rid of it. If the tumor is very advanced, we don't operate and do some palliative care. So here, I think the focus is slightly different in CA breast. If the tumor is small, or even in stage tumor, if the tumor is very early, and if the patient can be left alone for 3 months in this COVID times, I would wait. But this is, and also the risk stratification becomes very important. You should be able to assess, even in an advanced case, whether it's how things are with a multidisciplinary team. For once, the MDT teams are your very close friends because they can save you away from certain death after the surgery due to COVID associated with or without SARS virus in a postoperative patient. This is a patient who's 49 years, and she's a very fit patient. I mean, she's not a diabetic, not a hypertensive, not a cardiac case, and she's a very active lady, and she came with a tumor of 15 by 15 centimeters left breast. Practically, there was some limitation, not a total fixation to the breast. I did a FNAC, and she was unfortunately triple receptor negative. So she came at a high risk, and we did a PET scan. It was T4N2M0 lesion. So we, in fact, just before the COVID time, we had referred her to the multidisciplinary team, which involved another hospital getting involved. There, one oncologist patient went and had 4 fractions of CMF and radiotherapy. And subsequently, just when the lockdown was going on, she came and saw us and told me that she required, according to the team, we wanted surgery. I spoke to the oncology team. They said, yes, requires surgery. But due to the radiotherapy, there was a little bit of excoriation at the lower part. So waited for about 2 weeks for it to go. And we assessed her again. And this was a CT done at that time. She had a repeat PET scan also, which showed us the tumor had regressed. The nodes had become smaller. She was T4N1 M0 at this time. And she was a very high, though the tumor was fairly advanced before, tumor had regressed to some extent. But we know it's a bad tumor because it's triple receptor negative. And she's a very low risk patient from the risk stratification point of view. And I asked her, why don't you have this surgery in the same hospital where I referred you? She said, look, if I go there, I will get COVID. I don't want to enter the ICU. And this is something I learned from the patient. Here, instead of they putting the patient in a general ICU where there may be COVID, may be positive or negative patients, it's better to take the ICU to this patient. And so I spoke to them again, and then we planned on surgery for the surgery we normally would have done with this tumor was a mastectomy. What was planned was mastectomy and a latissimus dorsi flap with a skin graft to the donor area. So this we knew is quite an extensive surgery and involves a lot of postoperative dressing. And here in this COVID setup, what we did was a radical mastectomy, and we closed the skin. It was slightly a little bit under tension, and I discharged her on the second postoperative day. We did not only with me, but also with an oncosurgeon, so-called really qualified oncosurgeon as well. So that there were 2 pilots in this team, no unnecessary people in theater. The surgery was done with a minimal timing, very few people, and these are all things we have to do. So we may have a locally advanced lesion that will regress a little bit, but we knew that if it didn't go in, we had multiple opinions on this, but we all agreed on the same thing. If he lost his window, the patient might have recurrence. So I'm still waiting for the biopsy report. I have, in fact, discharger brought her back, had a look at the wound, little bit of tension, but there's no gangrene of the edges. And I know what you've done is the right thing. She's got a drain, and we're not going to remove the drain for 3 weeks. We are not going to remove the stitches for 3 weeks, maybe a bit longer. So these are all things we have to do. In a patient, even the so-called locally advanced is becoming, when they get the window, you must go in and operate. And this patient varies from person to person. Again, the teams are very important. Over to you, Randeep.
Dr. John, you can carry on. This one slide, you can just read these high priority areas. Would you do a surgery? That's what's the recommendation. Would you actually do these surgeries, or would you just say you want to wait still? Just go through the 5 recommendations here.
The breast surgery complications, bleeding indications. Yes, I think if it's acute setup, then you should operate. No questions about that. Complicated reconstructive surgery, yes, I think you do not want to reoperate on these patients, and you do not want very prolonged dressings, not only for you, but also for the patient. You know, if she comes to the hospital, where hospital is not the best place for these patients, and chemotherapy and radiotherapy wise, they are more prone at risk. So you want to cocoon them. The word is cocoon. Like old people, though she is 49 years, age has got nothing to do with it. She's 49, no comment, but still I'd like to cocoon her because she is more drastically immunocompromised. That's something we have to think.
Dr. John, just to add, this is what it says is complications of reconstructive surgery. So what you actually mentioned that you did not take the flap because there is a high chance of, so make it simpler because there is always a chance of ischemia. That's correct.
Short and avoid blood transfusion. Her HV dropped to 8.4, almost to 8. I normally might have given blood, but we didn't because we don't know. They don't do COVID tests of the blood in the blood bank. So these are all things you should avoid. And the last one is breast cancer surgery during pregnancy. Multidisciplinary team should be consulted? I guess so. Yes, certainly. These are aggressive tumors. The biology of the tumor is very important. And if the biology is going to be very bad, probably it's worthwhile counting more on the chemotherapy and the radiotherapy. And if necessary, the child plays less of a role unless the mother is very keen and the parents are very keen. The child plays less of a role in deciding on the life of the mother. That's the way I would look at it.
Thank you, Dr. John. So we move on to the next next organ, the liver cancer. Here I invite Dr. Rajesh. That's his case. Dr. Rajesh, please take over.
I have actually chosen 2 cases since liver and gallbladder cancer was given to me. So I've chosen 2 cases, one from each, and tried to think in my own mind as to how the decisions would change in the COVID times. So this is one patient whom we operated, I think, at least about 2 years back, and who's at the moment recurrence free. He was a 78 years old male with a weight loss of 10 kgs over 6 months, anorexia for 2 months, pain upper abdomen for 15 days, hypertensive, diabetic, hypothyroid, and you name the comorbidity and he had it. His hemoglobin was all right, alkaline phosphatase was 156, albumin was normal, bilirubin was normal, prothrombin was normal. Next slide, please. So this was the imaging, and that showed, if you can see the scans there, you will find this lesion in the segment 2 and 3 of the liver, which was approximately about 7 into 7 into 6 centimeters with a small necrotic component. And except for the left hepatic vein, which was attenuated, all the other vessels were good. And we did the elastography, and that suggested the remaining liver, which was non-cirrhotic. So a good liver there. And we did the PET scan, which showed that there was no spread anywhere else. And the PET scan was also suggestive of a good FDG uptake and suggestive of an HCC. Next slide, please. So 2 years back, we did the laparoscopic left hepatectomy, and we removed this multilobulated left lower mass. Rest of the liver was normal. Tumor was not involving any subjacent or adjacent organs, no peritoneal deposits. And the equipment that was used was lab CUSA, lab harmonic, staplers for major vessels, hemolog clips, and LIGA clips. And the biopsy showed a well-differentiated HCC. And you can see the picture of that patient. This patient was discharged on day 4, I think. Now, when I tried to look back at this particular patient, and if say I got this patient today, I think many things are going to change in my own mind. One is, we have from the point of view of COVID, we have a patient who is a high-risk patient because of his age, his comorbidities. But this patient perhaps is not COVID infected. So I am going to base my strategy on one, making sure that he is not a COVID patient to the extent as much as possible. Secondly, discussing with the patient what are the possibilities of being COVID positive and landing up in a complication in this scenario in the hospital. My hospital at the moment, fortunately, although Jaipur falls not in the green zone, it's a hotspot, but my hospital fortunately has not had a COVID patient. It's not a COVID designated hospital. So perhaps it falls in the green zone. But I would like to work up this patient along, like this patient had a CT triple phase upper abdomen and PET scan, but I'll make sure that this patient gets a CT chest along with that. I would then we have had guidelines from the government, we can now do the RNA PCR. So I'm going to do the RNA PCR plus the antibody test. I understand ICMR has asked us to wait till the clearance, probably for the next 1 or 2 days. But I believe that clearance will come in the 1 or next 2 days. If we get good kits, we must do the antibody test. Based on that, I'm going to counsel this patient for 2 possible ways to move ahead. One, because I think he's a good candidate for surgery, looking at the favorable tumor characteristics and a good liver which is non-cirrhotic. So there is an option for a curative resection there. And at the same time, the second option, wherein because of the implication of COVID, we can try and postpone surgery and subject him to local ablative therapy, or say TACE, transarterial chemoembolization, or if the patient is not willing for that intervention, also systemic therapy. Now, this decision will rest on the patient. I will give these 2 options, discussing advantages and disadvantages of both. But once the patient decides that I want to take the curative resection further, my approach towards planning and executing the operation will be different. One, as I mentioned, I will definitely do a set chest CT, RNA PCR, antibody test. Having done this, I'm going to send the patient home. This patient will not get admitted. This patient is going to stay home for 7 days. I will make it sure that we have a video consultation with this patient almost every day, me or my team member, making sure that this patient is not developing any symptoms. This is particularly to cover those 7 days wherein the results of PCR and antibody might be false negative and the patient might still develop symptoms. And having stayed at home, on day 7, we admit this patient. We do the IgM antibody again, make sure once again, do the chest CT once again, make sure that this patient is not COVID positive. Now, when I'm doing all this workup, basically I'm trying to reduce the risk for the hospital staff and the hospital environment. Once I've made that sure, we admit that patient and we plan for a surgery. The surgery, in my opinion, at this point of time, with the kind of understanding that we have, will not be laparoscopic, because there is a chance for aerosolization. We must realize that at this point of time, the current knowledge tells us that the virus does not exist in blood. There is viremia till about day 11 after the patient suffers, but there's no bloodborne transmission. But at the same time, gastrointestinal tract and the biliary tract, they are acting as a hub for the virus trafficking. So expect a high viral load in the gastrointestinal lumen, expect a high viral load in the biliary lumen. And be prepared when you operate upon these patients to protect yourself and your team and the anesthetist from this high viral load. And based on that, I would probably go ahead with an open surgery. I will avoid using ultracision or QSUP because there is a high smoke generation there, and use the age-old technique of digitoclasia or caliclasia and use staplers, and do the standardized surgery. Left hepatectomy, standard left hepatectomy is a very predictable operation in such a patient, and most of these patients will do well, and perhaps go home on day 3 or day 4. That's my personal belief. I would invite any opinions if other panelists or the moderator has.
So excellent points, Rajesh. So what you've basically enumerated is extensive testing for COVID, quarantining the patient for 7 days, and an open surgical procedure. Now, let's say this patient had a normal looking liver. If this was a cirrhotic liver, will your treatment change here? Because we know the prognosis with a normal liver and this resection is pretty good, but with a cirrhotic liver, it will change. Will your treatment modality change?
Definitely, I have to be 100%, 200% sure before I decide upon the strategy whether this patient is cirrhotic or not. So many things will change. If he's a cirrhotic on preoperative investigation, he obviously does not go for this kind of resection, which is about 50% of liver volume, and when he becomes a high risk for a curative resectional surgery. This patient then goes for local ablative therapies in the form of RFA, or maybe RFA combined with TACE if indicated.
SAGES has recommended that you should take tumors only less than 3 centimeters, consider them for surgery. But then, like we said, we can't possibly agree with SAGES all the times. So with all due precautions, you are okay with doing a tumor which is about 6.5 or 7 centimeters. Is that correct?
Well, actually, why SAGES says that is because SAGES is considering 2 or 3 centimeters tumor in a different location, wherein we are going to go for a curative segmental resection, or maybe a kind of a not segmental, so say peripheral resection and things like that. And they have not mentioned whether they are going to consider this in a cirrhotic or a non-cirrhotic patient. If we have a patient who's kind of, by and large, proven non-cirrhotic, the tumor size does not matter as far as the tumor characteristics dictate that it's going to be a straightforward anatomical dissection with minimal risk. I mean, the risk of morbidity is less than 5 to 7%, and the mortality is less than 1% in this kind of a tumor in a non-cirrhotic patient in a high volume center. So it all depends on the experience of the team and understanding of the tumor and the patient risk factors, I think.
Colorectal metastasis or metastasis in the liver, no confusion. We will go for a chemotherapy here.
Chemotherapy and local ablation.
Yeah. So let's go to the next one, the cancer gallbladder, and then we can take the, opinions of the other panelists as well. Again, your case, Rajesh, please go ahead.
And once again, I chose this patient of cancer gallbladder, 86 years old female, pain right upper quadrant, anorexia, but non-jaundiced. There was a fundal mass. We did the CT triple phase, and that showed that there was this tumor in the fundus in the body region, and it was infiltrating the liver. The fat plane was obliterated, but the duodenum and colon were spared, and there was no node seen, and the vessels were all clear. So it was a good resectable carcinoma gallbladder, and that's what we did. So we did a laparoscopic radical cholecystectomy with the entire hepatoduodenal ligament clearance. This was, I think, at least about 1 year back. The operative findings included a liver micronodular, but the preoperative liver function tests were normal. Now, this micronodular liver was perhaps not cirrhotic. We took a biopsy, it came out normal. It was because of her age when the liver looks slightly different, slightly, puckered, you can say, or scarred. So these were the operative findings, and the histopathology showed a moderately differentiated adenocarcinoma of the gallbladder. And I particularly chose this. And the point that I would want to make is that when it comes to cancer gallbladder, it is a cancer with a known natural aggressive behavior. And this cancer cannot wait for 2 or 3 months because you expect a stage migration in most of these cases. And therefore, even at this point of time, if your setting falls in a green zone, I think you should take all the precautions for the safety of the patient and for the safety of the staff and go ahead with your usual protocol for managing the cancer gallbladder, because cancer gallbladder, one, there is minimal role for bridging procedures. And secondly, the tumor biology is very aggressive. So at this point of time, to my understanding, there are no guidelines in the world. Cancer gallbladder is not very common in many other countries. India is a very high incidence center. So the cancer gallbladder treatment should not change. By and large, the only effective option for these patients, and particularly for this T2N0 disease, is a surgical curative resection, and one should not wait for it. Of course, taking care that we follow all the guidelines based on the understanding of COVID. It's different from how we deal with, say, a liver cancer and how we deal with a gallbladder cancer.
Very good, Rajesh. And again, you would say that instead of a laparoscopic radical cholecystectomy, you would be doing an open surgical procedure.
It has got to be open, yes.
Yeah. So any comments from our esteemed panelists? Anything? Yes, Dr. John, you want to make a comment, please. Please unmute yourself.
Oh, okay. Unmute.
Yes, we can hear you
now.
Now
Can you hear me?
Yes, yes.
Okay. I'll play the devil's advocate here. This is an 86-year-old lady whom I normally wouldn't even want to bring to the hospital. And so we know the tumor is an aggressive tumor. So in fact, I would explain everything to her, and I might have left her alone. I mean, if I'm 86, if I go to the hospital, I'll get a tumor, especially after surgery, where I'm a little bit compromised. So I might leave alone. That's one option. I was just thinking. That's all. Nothing else. Not a criticism. It's great work, absolutely. But I might have discussed this option with the family. That's all.
Anyone else to add anything? Yeah.
Can I come in?
Is that, yeah, Dr. Anil, please.
Anil Heror, yeah.
Please
so, Rajesh, excellent work. And this is an example. What was the blood requirement? Because that is also a critical decision that needs to be taken in COVID times, because the team has to be very, very tuned to doing these surgeries. Your blood requirements have to be low. You don't have the kind of blood bank backup that you normally have.
Yeah, by and large, it is zero. I mean, I'm sure, I won't remember offhand, but I'm sure both of these patients did not.
Yeah, that I expected so, because these are the units which can usually do these surgeries in these times, because otherwise somebody who's not doing large volumes should not attempt these surgeries in these times, at least, because the kind of backup that is required for doing major resections is not available.
Yeah.
Thank you. So we move on to pancreatic cancer. And so this is the presentation from Dr. Kriplani, sir. Please go ahead, sir.
Thank you, Randeep. And about the pancreas, which is a very different organ than the GI tract, being a solid organ. And, it's a totally parenchymal organ. So we are going to discuss only about the pancreatic neoplasia. And most of the pancreatic neoplasia are malignant. And they are very aggressive tumor. They advance very rapidly locally. And tumors of the head of the pancreas and also particularly the body of the pancreas, they metastasize very, very rapidly. Also, unlike CA breast that John discussed, surgery remains the mainstay of treatment, and chemotherapy role is not so extensive as it is in other GI malignancies. And neoadjuvant treatment is generally reserved only for patients who have locally advanced disease. A patient who is clear-cut resectable should undergo a resection for the best or optimal outcome. And similarly, in distal pancreatectomy particularly, the gold standard, more or less it is agreed that laparoscopy is the gold standard, because the outcome in the morbidity is very significant. The head of the pancreas still, laparoscopic Whipple procedure is an evolving stage, and we do not know as yet whether doing a laparoscopic surgery for a head of the pancreas cancer is beneficial, but for the body and tail of the pancreas, doing a distal partial pancreatectomy, avoiding a long muscle cutting incision laparoscopy definitely is the preferred and perhaps the gold standard method of treatment. So we have to decide which patients we should operate and which patient we should not operate. Generally, we should be operating almost all patients because of the reason that these are all very, very aggressive tumors, particularly pancreatic adenocarcinoma, head of the pancreas, which are also not only advancing very rapidly, but are also causing obstructive jaundice, which might progress and which will affect the outcome of the patient, the cholangiocarcinoma, the duodenal carcinoma, and the ampullary carcinoma. Now here we also have to see that among these group of tumors which are causing obstructive jaundice, whether you can temporize the treatment by doing an endoscopic stenting so that their jaundice comes down and you can have a little longer time to wait. Now again, this longer time will depend upon which COVID wave or which COVID situation you are in, about the geographical location, about the facilities in your hospital, and whether the patients of adenocarcinoma of the head of the pancreas, what is the vascular involvement in these patients? If these patients have a tumor which is very small in size, 2 centimeters, 3 centimeters, it is well away from the portal vein, it is not involving the hepatic artery or the gastroduodenal artery, perhaps this is a case where despite jaundice, you can do an endoscopic stenting, give these patients chemotherapy and wait so that preventing these patients from progressing. But if these are borderline patients of the head of the pancreas, where you have maybe around 130 degree, 140 degree, circumference of the portal vein involved, where the SMA is partly getting involved or the GDA is completely involved, and you know that it is going to add to the hepatic artery, then you may have to take decisions. In different decisions, your decisions will be different, and perhaps surgery becomes more emergent. And also, it also depends whether these patients are receiving earlier neoadjuvant therapy or not. If you start on them on neoadjuvant chemotherapy, you have to critically, periodically monitor the response in these patients. And those patients who are responders to chemotherapy in cancer head of the pancreas, perhaps you can delay surgery, you can add more dosage, more schedules of chemotherapy in an attempt to keep these patients limited. But if these patients are not responding to chemotherapy, then the treatment becomes more urgent. However, on the other side, if you have asymptomatic patients of neuroendocrine tumors of the pancreas, perhaps there is really no urgency to operate on these patients because these tumors are rather slow-growing tumors. They assume large proportions without invading the neighboring structures, and even if they invade the splenic artery, then mostly splenectomy can be combined. So here is a patient whom you can see. This is a neuroendocrine tumor of the head of the pancreas that we treated about a year and a half back. Next slide, please. And that is the Dotanox scan, which shows that this area is concentrating the radioactivity here, and rest of the head of the body of the pancreas are free. So in a non-COVID situation, these patients should undergo a standard laparoscopic distal pancreatectomy. Can I have the next slide, please, Sandeep? So that is the spleen, the pancreas, in most of these patients, neuroendocrine tumors, which are rather large, which are very in close proximity to the hepatic artery, generally a splenectomy is added. Though if the tumor is very well clear from the splenic artery, you can also try and do a splenic preservation, distal partial pancreatectomy. Next slide, Sandeep. And that is the resected tumor with the spleen lifted off. The pancreas has been divided here and has been lifted off. And this, you can see the staple line. So these NETs, in a standard situation, will warrant a laparoscopic distal pancreatectomy with or without preservation of the spleen, depending on the local factors. Now the question is, all these pancreatic surgeries are longer surgeries. They are of longer duration surgeries. They may require post-operative stay in the intensive care unit, and so their resources you have to look at the resources available at that particular COVID wave. And these are not surgeries which a surgeon can do with only one assistant. You need more people. So when you involve a bigger team, there are more people at risk, and it is a longer duration of surgery. But the question is that these patients, these tumors are not very aggressive tumors in the body and tail of the pancreas. So you can defer these surgeries, wait for these surgery, let the COVID wave pass off or let the COVID wave subside, because waiting for about 8 weeks or 12 weeks in these kind of patients is not going to make a very material difference in the outcome. So if I get this patient during a COVID wave, perhaps I will advise this patient, counsel this patient to wait for further days, maybe monitor him with a CT after 8 weeks, see the progress of the disease, and wait till the wave is subsided. Another very important thing is that these patients should not feel that they are getting less than the best treatment they should take during a non-COVID situation. And another very important aspect is that in these critical areas where situations are not very clear, you should preferably not take these decisions alone. It is always better to have your local tumor board active to involve these discussions in these patients and take a consensus or a majority decision with a multidisciplinary approach and not taking the responsibility alone, because subsequently after 2 months, 3 months, 4 months, if something happens, then you are not alone in that treatment and the responsibility is shared. Needless to say, as Rajesh said, that we must make sure that these tumors, the patients are COVID negative, and a CT chest should be essential in the protocol of all major abdominal surgeries which are going to last for more than 3 hours, or which are going to last longer, to make sure that they are not suffering from COVID. Similarly, in a distal pancreas, in a cystic lesion of the pancreas, in the distal tumor, unless if you can clearly diagnose and you can do an endoscopic ultrasound, aspirate the content, do the tumor markers, and if they are simple cysts or they are non-malignant cysts, they are serous cysts, then perhaps you can wait for these patients, defer the surgery to a more appropriate time. And if they are mucinous tumors, then you must exclude the IPMN, because IPMN amongst them is a more rapidly advancing tumor, but even that can wait for 2 months or 3 months, and the surgery in the body and tail of the pancreas is generally not very emergent. There's really no need to give them any chemotherapy, give them any adjuvant therapy, just monitor them closely. And during their follow-up period, it is very important that you should not make the patient visit the hospital. It is one time where the follow-up should be extremely exploited by a teleconsultation. They can get their CT scan done, they can get their test done, and they can send you the report. So teleconsultation in those patients who are waiting, or those follow-up patients which you have operated earlier, should be a very essential part, so that you do not come anyway in the physical proximity of these patients, and these patients do not come into the society. The situation is totally different for tumors of the head of the pancreas, where you have to do, because these are more aggressive tumors, where you have to do a Whipple particularly, and then in these patients who are causing obstructive jaundice, you have to differentiate between head of the pancreas and ampullary carcinoma, because if the head of the pancreas tumor, it is more emergent to operate them earlier as compared to ampullary tumors, which are rather small growing tumors, which give you a little more time. The jaundice can be ablated by endoscopic stenting, and they give you little more time. Similarly, about duodenal carcinomas, if they are causing obstruction and they are small in size, they are easily accessible endoscopy. You can assess their extent of the disease. Perhaps you can defer these patients for 6 weeks, 8 weeks, and not longer. So they would fall in category B according to the recommendation, where the treatment is not immediately urgent, and you can defer the treatment. And you, depending on your philosophy, whether you want to do them open or laparoscopic. Laparoscopic so far has shown no definite improvement in these patients. So these patients, even if otherwise you are doing these patients by laparoscopy, in this COVID era, all these patients should be operated by an open approach. While tumors of the body and tail of the pancreas, who are rather non-malignant, should preferably be deferred surgery, and being monitored during this patient, so that you operate them when the COVID phase is over. This is what these slides show, a laparoscopic Whipple procedure, but the Whipple procedure, for such a long procedure in which there are so many pores, it's a long duration, the carbon dioxide and the fumes will leak around the port. It is very easy to say that your USA should be minimum as possible, but as the surgery goes longer, the fumes and the smoke leaking out around the port is a reality. So just using the filters will not suffice in all these bigger surgeries, and they should preferably be treated by an open approach.
Thank you, sir. These are the recommendations by SAGES where, like you mentioned, that IPMN, CIS, low-grade neuroendocrine neoplasias observation is what has been suggested. If metastatic, of course, targeted therapy needs to be done. Resectable, then resection or consider chemotherapy. What you've mentioned as periamp, you can probably wait for some more time, but CA head of pancreas, resectable, you would like to go in and do a surgical procedure and do a Whipple's procedure.
CA head of the pancreas, if it is a small lesion, because CA head of the pancreas, sometimes a small lesion can cause obstructive jaundice, and a large lesion may not cause obstructive jaundice because it all depends on the proximity. So perhaps these smaller lesions, you can even give neoadjuvant chemotherapy and watch the progress of the disease, and perhaps defer them to a more appropriate time when the COVID phase in your area or around the country might have passed off. But borderline tumors, particularly who are more than 90 degree, encircling the portal vein or are in close proximity with the SMA tumors, are the uncinate process of the pancreas, because they get stuck to the SMA very fast. So tumors of the uncinate process, they may not be causing jaundice, but they should be operated as early as possible because their unresectability becomes very higher. So the size of the tumor, the location of the tumor in the head of the pancreas also will matter a lot in your deciding about the treatment.
So these are the guidelines which are the high priority guidelines for surgical procedure even in COVID times. If you can read and go one by one and see if you are in concurrence with these, or you have any other points to mention, right from 1 to 6. Sir.
Resectable cancers, primary or after the neoadjuvant treatment, including resectable cystic lesion with suspicion of malignancy. Well, I will say that cystic lesions with suspicion of malignancy, they may not be a very high priority tumor, because currently you can do an endoscopic ultrasound, you can aspirate the cyst, you can do the tumor markers, there are certain characteristic CT lesions. So, in these cystic lesion, you should exhaust all your available resources to ensure whether or not these tumors are malignant. If you really exhaust all your sources and you have availability of all these investigations, perhaps in a great majority of patients, you will be able to separate out malignant lesions from non-malignant lesions. And then you can decide your priority depending upon the malignancy or non-malignancy. So suspected lesions, I would say, should be investigated very thoroughly to exclude or confirm a benign disease. Borderline cancer in the patients not fit for adjuvant chemotherapy. I think I'd like to add one more thing there, that these patients, not only who are not fit for adjuvant chemotherapy, but also the patients who have developed complications of neoadjuvant chemotherapy. These patients are the ones who should be taken up on priority for surgery. Endoscopic placement of biliary stent in case of biliary obstruction in non-resectable or metastatic cancers. Yeah, there's absolutely no doubt, because even in an otherwise non-COVID situation, if the patient has a metastatic disease, particularly from the pancreas, unlike all other GI tumors where a metastatic disease resection is an option, with head of the pancreas tumors, metastatic liver disease is rather a contraindication for surgery, and they should be treated with an endoscopic stenting. Endoscopic placement of biliary stent in case of biliary obstruction in resectable tumors with active cholangitis and bilirubin more than 250 micromoles, or non-resectable localized cancers assigned to neoadjuvant or palliative treatment. There is no doubt about these things, and they should be, we are in total concurrence. Post-surgery complications, obviously if a post-surgery complications requires surgical correction, then surgical correction remains the only way. But you also have certain situations in the post-surgery complications which you can control, like a arterial blowout or vascular bleed. I think the preferable treatment should be to do an embolization and control the bleeding. Unless this anastomotic leak, definitely bleeding, I would say you exhaust your invasive radiology and involve them. Acute pancreatitis and fistulae. Again, the definition of fistulae is if it's a low output fistula, perhaps, and you have a jejunostomy in place, or you can put a nasojejunal tube in place, then the low output fistulas can be managed non-operatively. But if these fistulas are large volume fistulas, if there's a complete disruption of the of the pancreatico-enteric anastomosis, then they are going to need mop-up. And particularly those fistulas which are low output and which do not have associated collection, which are a controlled fistula, then you can temporize the situation by nasovaginal feeding and jejunoscopy feeding. Historical assessment CT scan or EU is guided in case of urgent therapeutic complications such as curative resection or symptomatic release. So these are my views about the recommendations.
Thank you, sir. So we'll move on to the next one, which is the stomach cancer. And here I would like the inputs from Dr. John. This was the SAGES guidelines, which were published about 10 days back, that T1A cancers, we recommend delaying these procedures. You do some endoscopies. This is an endoscopic resections, whether you should do an endoscopic resections or not. So the recommendation is that these procedures should be postponed till you find the best window and then do it. T1B and T2 tumors, the suggestion was that these patients need surgery. However, a weak window again to find out and then go in and do the surgical procedures. Anything between a T3 and above, then ideally a neoadjuvant chemotherapy is recommended. And then find a window maybe 3 or 4 months later. These are the guidelines which have been mentioned, which have been sent by you. So Dr. John, please.
Thank you. I just wanted to mention that the guidelines for any cancer surgery is usually based on the staging. But here we have to be concerned about how the patient is. For instance, see esophagus, for instance, could be on a 25-year-old chap, 23 years I've operated. It can also be in a very old person. That is one. Age only plays a major role. The other thing is the status of the patient. Many of these patients in the upper GI tract are smokers. So the lung needs care after the surgery. And we know after any abdominal surgery, you can have a problem of lung infection, chest physio and all that comes in. A lot of aerosolization will happen. So these are important things. But generally what I've done here is taken from the upper GI surgery of the Great Britain and Ireland, which makes a lot of sense to me. They've categorized from one category to the last one, depending on, provided that the general condition of the patient is quite all right. There should be really no great comorbid situations. Age should not be really on the higher side. So if higher side, probably best, I mean, we all have to die sometime. You have to categorize these patients that way too. Provided they are all fit in with a reasonably acceptable strata, then you look at the tumor, curative therapy with 50% chance, by all means go in and operate. These are category 1. But if the curative intent is less so, around 15 to 30%, even a T3 with low complications, you can look at it kindly and go for it, especially if it has already responded, minimal response to CT, but however, the tumor grade is still T3, the level is only T3 and N1, probably is worthwhile going in. Whereas if there's a non-curative state with a high chance of a patient going to live for more than a year, it's worth it. But where the chances of low and the high risk of complications are high, especially if the patient is going to stay in the hospital for a long time, is probably not worth it, because even if the patient is negative COVID-wise, subsequently in the hospital might pick up the infections and expose the operating personnel and the ICU personnel to a lot of lung problems of the patient. So I think it's got to be a lot of common sense here, and I would totally go by the British method of prioritization for elective surgery. Over to you.
Yeah, thank you, Dr. John. Obstructing and bleeding gastric cancers, what would be your take on these patients having gastric outlet, stents versus doing a surgical procedure, bleeding again? Let's say IR and endoscopy has failed. What would be your option there?
IR endoscopy has failed. If the facilities exist for an embolization, I would go in for embolization, but it depends on the staging. A large tumor, I would go in for an embolization if possible. Otherwise, going in for a gastrectomy is fine. For exploration is fine. I would go in in an emergency situation more with a laparotomy than by a laparoscopic method. Perforation, I would be tempted to more do a laparoscopy, take a stitching and finish it up rather than do a partial gastrectomy. But knowing very well that you may have to go in later, if you can tide over for some time, it's okay. But if the situation is not great, I would still go in and do a laparoscopic gastrectomy in these patients if they are if it's feasible, because I do both and wouldn't hesitate to use laparoscopy here. But the only thing you must remember is when you do a laparoscopy, it's very difficult to just stick to the so-called just diathermy for these patients, though that's how we all started. We all started doing laparoscopic gastrectomy by doing just monopolar and bipolar cautery long ago. And I just got this aerosol for cautery is 0.007 to 0.4 millimicrons. Laser is in between, but ultrasound is 0.35 to 6.3. This is going to play a major role. With an ultrasound, the size of the particle of the smoke is also going to be a bit bigger. So these are all things you have to remember, even in a COVID negative patient, because you're not only using a technology of what you're capable of, but you're also worried about the team. As Ajay Kriplani very ably said, whatever you may say, if the surgery is going to be very prolonged, if the smoke is going to be a lot more, and if you're going to use harmonic scalpel all the time, it's probably best to think in terms of the team and keep the surgery shorter and expose them less, because you're not only worried, it's not your skill that matters here, but also on the care of the team. That's very important here. Over to you.
Thank you, Dr. John. Any comments or any statements from any of the panelists, particularly pertaining to pancreas or gastric tumors, gastric cancers? Dr. Rajesh, Dr. Anil, anything to add here?
No, nothing from my side. I think it has been very beautifully elaborated by Kriplani sir and Dr.
Dr. Anil Harur, anything to add here? Dr. Subiraj, before we move on to colorectal malignancies. Dr. Selva Sekhar, anything to add here, please?
For the colorectal malignancies as such, basically, as I alluded to earlier, the patients nowadays who are referred are prioritized based on those who need surgery within 48 hours or maximum of 72 hours, which are usually those with peritonitis or obstruction. If it is an obstruction, then we have to seriously think about stenting, as I mentioned earlier. If it is peritonitis, it is a washout and a stoma rather than a resection. The reason is, like most of the discussions we have had today, it is all about risk and benefit. It is not just the risk to the patient as we used to talk about in the past. It is a risk to the patient, the staff. It is not just the surgeons, it's the theater staff, because if a patient who has had a surgery who is COVID positive, and if the theater staff is all infected, then unfortunately it means that it brings out the whole infrastructure down for whatever time it takes, So that is what has added more complexity to this current.
I think I'd like to reiterate, being a very,
who are having surgery within 4 weeks, which are most of the elective cancer work. There's been a clear guidelines on what are the patients who fit in this criteria, which has been given. Some of it fits in, and that is what we use during our MDT recommendations. And we add in here, as you know, the documentation is very important. So what we are trying to do is, when we do a letter, we say that in the current COVID pandemic, this is the agreed recommendation from the MDT team. The reason is because in a couple of years, people may forget what a pandemic was. Hopefully, it happens, but then we know that it was taken in that environment. So that is the reason why we documented, saying that in the current COVID pandemic, this is what we have done. It may not be the best evidence of what we normally do in the pre-COVID environment, but it is the best we can do in the current climate, is the thinking behind it. And the same, patients-wise, apart from the comorbidities, we also stratify them based on their vulnerability to COVID, which is basically patients who are less than 70 years or patients who are over 70 years, because that seems to be the cutoff. In India, it may be a different criteria which needs to be used because the longevity and things are slightly different. And when it is a vulnerability score of 3, which means that patients are extremely vulnerable, we have to think twice. Unfortunately, we need to understand that there are going to be a significant number of patients who are going to lose, which means that basically they were going to suffer from their cancer or die from this cancer during this current pandemic, which is completely not the principle to which the clinicians are used to, but we have to accept that that is a fact because of the way the situation is evolving. And it is a difficult concept, and that is the reason why there's going to be a lot of emotional issues among the clinicians after the pandemic is over. From the clinicians, same as people are talking about the post-traumatic stress disorder, which the military go through after a war. This may be something which we may see among the clinicians. So it is all, to some extent, interesting, but a challenging concept which we have to live with. The third issue which we have to take in a cancer surgery is the environment in which the surgery is offered. Green zone or a COVID light or a COVID free, it's very difficult to have a COVID free environment. There will always be a COVID positive patient in a hospital as far as we have seen. The other concept which is coming up in the NHS is having cancer hubs, having a hub and spoke model, because it fits in with the healthcare system, which is the NHS. Like in Manchester, the Christie is a cancer hub where we take referrals from other hospitals who have gone through the MDT, have their surgery alone at the Christie, and then sent back once the patient is discharged for further follow-up and management. So these are the ways by which we have dealt with cancer surgery so far. And certainly the techniques are different, less anastomosis, more stoma, which fits in with what the NHS does, but I'm not sure how feasible it is in the Indian context. And that is where I think you guys as experts needs to make a decision. It's all well and well to have the the guidance or guidelines from different parts of the world, but I think it has to be tailored to what India needs. Thank you very much.
Thank
I'd like
you.
to come
yes,
in.
Yes, Dr. John, please.
I think we really have to be cognizant of who's watching. I think we have a wonderful audience here, from surgical oncologists to general surgeons to dedicated minimal access laparoscopic and robotic surgeons. I'd like to highlight this is an evolving and I would say an intense situation. Really have your MDT in place, even though you may be a luminal surgeon, so to speak, and have this constant conversation with the family. You really have to, at this period, look at the psychological status and well-being of the family, because they're the ones making the decisions. And I find that in the current context, very important. And you really have to discuss all the viable alternative pathways also, because few weeks from now, you and I don't know how things are going to evolve. And you should have the ability to break away to a different alternative if the situation demands. And please document, as mentioned by some. We right now are documenting that in the current context of a COVID pandemic, these options are being discussed. Do not forget that in the heat of the moment. So understanding the nuances right now, this is really intense, not just interesting. You really have to be at the top of the game, discuss all the options, because people are under stress. They're really looking up to you. Have the MDT in place, constantly discuss with your team and with the family. It's more intense than what otherwise is for an oncology patient. It's not cut and dry that you plan now and a few weeks from now, this is what you're going to do. It could be very different. Thank you.
Thank you, Suviraj. So we continue. This was published in Lancet that the analysis is of all the Italian patients who died because of COVID-19, 20% actually had active cancers. Gethin Williams, a colorectal surgeon in Wales, he said that the rate at which COVID-19 is going through, there'll probably be no colorectal surgery for the foreseeable future. And he's being as pessimistic, and he says without treatment, some cancers are going to obstruct, the others are going to metastasize. So things are not good, but we need to face the situation. So we go on to colon cancers here. And this is your case, Suviraj. So please continue. Suviraj, are you there? So I think we've lost him. We'll see if we can get him back. Meanwhile, what I'll do is, Dr. Anil Arur, are you there with us?
I'm very much here.
Yeah, so till we get Dr. Suviraj, what we'll do is that we'll go to your case, please. This is your case. Please go on.
So this was a case we have actually operated during COVID times. So this was a 26-year-old young boy. He first saw me in January and he had come with just pain. So clinical examination did show growth at 5 to 6 centimeters from the anal verge. Non-metastatic, these are his colonoscopy pictures. Biopsy was a moderately differentiated adenocarcinoma. If you could go to the next slide. And his MR on the, this is the pre-neoadjuvant MR. It showed an extraserosal spread which was there. It also showed a few nodes, but it was still non-metastatic. So your CRMs were threatened. There were nodes, so it is obviously a T4N1 kind of scenario. And that is why the obvious thing was to go ahead with neoadjuvant chemo-RT. Remember, we were not on the COVID time that time. This was January, so there was no inkling of the impending pandemic at that time. So we went for the routine. I normally prefer a long course chemo-RT. So we sent him for a long course chemo-RT, and that was 4 weeks of radiation along with capecitabine. Let's go to the next slide. And in early February, should I finish the case, Randeep, and then we can discuss, or do you want me to discuss in between?
Yeah, please go ahead. Go ahead with the discussion, please.
So if you could show the next, the post-therapy MR. So the post-therapy MR was basically in February, the guy came again. This was about the 6th week after the finishing the treatment. And that showed an excellent response. The nodes were no longer there. The CRM was no longer threatened. The bladder was clean, and that is why we said that we would go ahead with a laparoscopic anterior resection in the week following that. Normally, we have a policy of waiting for a period of 6 weeks and operating in the 6th to the 8th week. That is our policy currently at our institution. And that is also what is the norm normally after finishing neoadjuvant therapy. But then this was mid-March, and that is where COVID stuck. So then I had an extensive discussion with the family, and we said that there is evidence that we can wait for 2 or 3 more weeks, and we will go ahead. Then 2 weeks passed. This was after the Janta curfew, and in the first week of April, that is when the family started becoming really very anxious. Also, we looked up the literature. There are 2 interesting studies that are there. One, which is the GRECA 8 trial, which says that after 8 weeks, the benefit of waiting is just not there. You do not get any further surgical response. Versus this, there is something which is a total neoadjuvant therapy, where if you have complete response, then you can, actually go ahead with consolidation chemotherapy or wait and give just chemo radiation. But this was obviously not a case for total neoadjuvant, because there is a response, but the disease is still there. So you are not seeing a complete response. Though we can wait further, but the chances in this kind of patient, remember, he's a young patient. We know that young patients have more aggressive disease. There was extraserosal spread. There was a CRM threatening. CRM was threatened on the pre-op scans as well. There were lymph nodes which were there. So all these things make him a very high risk for recurrence. There is also a chance that if we wait longer, then we might risk distant spread. And that is something that worked on our minds. And that is why we went ahead with surgery. Now, what is the difference in decision that we made? The difference in decision that we made was we decided to go ahead with open surgery rather than the laparoscopic anterior resection that was planned. There were 2 or 3 reasons that we chose open surgery. One, This was early in the, when COVID was really hitting India, that the anesthetists were not really geared up with the kind of things that Dr. Thanakumar just showed us. The anesthesia protocols were not there. They preferred a regional anesthesia. That was the first thing. The second reason was we were not ready with smoke evacuators. We did not have a standard smoke evacuator, and we were still thinking on how to make the smoke evacuation system. Now we know that you do not actually need the commercially available smoke evacuators. You can make a passive smoke evacuator out of a simple suction tube with attached to an underwater seal and putting a filter in between. That is the kind of filter that you have with anesthesia that acts as a filter, and you can collect the suction, which can be taken and put in a hydrochloride solution seal. So all these things were still evolving. Interestingly, this construction of the passive suction has come in an Annals of Journals of Surgery paper. And interestingly, very rare to have a paper from the West saying that there is a low-cost solution for suction evacuation. So that is also an indication of time, how times have changed. So now we are having low-cost solutions coming from the West rather than from India or otherwise. So this is how COVID is going to impact us. So we went ahead with open anterior resection. We did a low anterior resection, and no covering colostomy was done. The patient had an uneventful post-op. Now, if I have to review this case and come back to it, would this patient have presented to me de novo? What are the kind of changes in management that I would have done? The first thing is there is now a recommendation to go ahead with short course chemotherapy and radiation, not long course. There are two reasons that are given. This was again an Annals of Surgical Oncology paper that came from the US. Why short course? The short course is talked about because of logistics. So you have less number of visits to the hospital, and that is why you would prefer a short course radiation than a long course radiation. Secondly, would I delay my surgery beyond 12 to 16 weeks, as SAGES has recommended, and as you can see the slide that Dr. Randeep has put up? I don't think so. I would disagree with SAGES there. Again, I would say that these are patients who are young. They have aggressive disease. They are not patients who are going to be, the disease is not going to be very kind to them. And that is why I would probably still go ahead with surgery after waiting for 8 weeks. Because beyond 8 weeks, as Dr. Saklani's group has shown, there are two things that happen. One thing is that the surgery becomes tougher. There is increased locally the bleeding is more, and the rate of complications is more. This is Dr. Saklani's paper that they have published, and that is why I would go ahead and probably operate. Would I choose a minimal access now? In this last 4 weeks, the change in thought process that has come to our unit is that we will now be a little bolder in doing minimal access. We now believe that we do have the necessary ammunition to deal with smoke evacuation. We now understand what are the kind of care that we take. Our protocols are much more evolved now, though I will not say that they are perfect, but they are much more evolved. The anesthetists are more comfortable. And as far as the experience is concerned, our unit is used to doing minimal access. So we are quite comfortable doing minimal access or laparoscopic anterior resection in the routine cases. That's why I would probably go ahead and now probably if this patient comes to me, I would probably go ahead and do a minimal access surgery.
Anil, you can very well covered. Can you just go through the high priority areas? These are the emergency situations wherein they suggest you should go in as soon as possible. Just go through them and your point of view there.
So, so these are the ESMO guideline, ESMO high priority areas. One is a radiologically confirmed intestinal occlusion in newly diagnosed patients, and I'll take the second point also of bowel perforation. Incidentally, we did have a patient like this. This was a patient on dialysis who went, who had an Ogilvy syndrome and had a cecal perforation. And this was really what scared us because we know that GI has the GI mucosa also concentrates the virus, though not as much as the respiratory mucosa. So we were really scared. This was the first time I operated in a proper PPE, and believe me, it is not fun. It is extremely difficult to operate with the hood on and wearing that proper PPE. It is almost impossible. You really need somebody to give you a neck massage after completing the surgery. Your ergonomics are all screwed up. You really have a lot of difficulty in operating in that. But I think it was for a good cause, because the moment we opened the abdomen, we had a gush of gas which came out. It was a perforation. So obviously you had that gush of gas, and that really sort of, to put it very, very succinctly, we were shit scared. So it was really shit, and we was really scared. And so I think that's a no-brainer. We have to go ahead with surgery. Again, massive gastrointestinal bleeding. This is an area where I would first exhaust my radiological armamentarium. I would like to do a DSA. I would see if I can plug the leak with a coil or something. And if it is not possible, then I would probably, there is no choice. Post-surgical complications. Here there are a quick, if it is a rectal leak or an anastomotic leak, I would probably do a stoma if it can be done quickly, because putting a stent in these situations is actually more difficult, leads to more aerosolization. A stoma is probably the quicker way to do it. Post colonoscopy complications, God forbid, again, it's the same thing. I would not think of doing anything fancy of putting clips or trying to put a covering stent, because again, these are procedures which lead to a lot of aerosolization. Post interventional procedures, again, the same logic applies. Bone fractures with spinal cord compression due to metastasis. I would not opt for surgical things in this. I would use non-surgical means as far as possible.
Thank you.
One additional point is about the use of stents, for acting as a bridge to intestinal obstruction. In COVID times, I think though stenting is a very, very good and very alluring option, I would still feel that going ahead with a quick stoma is a little better than trying to stent these patients, because as I said, endoscopy leads to much more aerosolization.
Thank you, Anil. We go to Dr. Soviraj for colonic cancers and treatment modalities. Dr. Soviraj, please.
Thank you, Randeep. This is actually a situation we're dealing with right now, and this gentleman presented to us just before the lockdown came into effect, and he had a recent history of lower abdominal complaints, altered bowel habits, and someone suggested outside, please get an ultrasound done, which pointed in the direction of a sigmoid mass, which was confirmed on contrast-enhanced CT abdomen, with which he came to us. And this, interestingly, also detected liver metastases. So that made it interesting. And from the word go, the COVID was a big issue. Where do we see the patient in my hospital or clinic? And could I have the next slide, please? So we actually set about, got his diagnosis confirmed, and got a sigmoidoscopy done, which showed a near circumferential growth in the distal sigmoid. They couldn't negotiate the scope beyond this because this was a long segment rigid mass. Biopsy was taken, which confirmed a moderately differentiated adenocarcinoma. Because of the metastatic status, we got the molecular genetics done. KRAS, NRAS, and BRF was negative. Serum CA was on the higher side, about 13. And he went in for a staging imaging. A PET CT was done, which confirmed essentially what the CT was showing. He had a hypermetabolic growth in the distal sigmoid. He had lymph nodes in the perisigmoid, as well as the para-aortic obturator groups, as well as the presacral groups. And then, of course, he had the liver metastases in both lobes confirmed, the largest being about 2 centimeters in the caudate lobe. So that was the status with which he went in for an MDT. Next slide, please. rather bulky growth. On MDT, it was decided that he would go in for a neoadjuvant chemotherapy, 4 cycles of FOLFOX along with cetuximab based on his molecular genetics. We would reevaluate after 4 cycles and then plan. Now, this is a live and evolving situation. It's been quite intense because of the stage of the patient, essentially an advanced T3, N2, and M1. And we're dealing actually waiting, he's mid chemotherapy, and we're waiting for the completion of the chemotherapy to assess him. We're constantly in touch with the family and the patient. He actually came in a few weeks ago with acute constipation. This was a real issue because what do we do if he's gone to obstruction? Do we stent him, which was the first thing that came to us? Or, do we go in for surgery and do a stoma? Fortunately, it was just rectal impaction and we got rid of that. And then now, every time he comes in for chemotherapy, he's going for screening, which is a matter of anxiety for the patient and the family. Now, down the line, this is what is really of concern for us. We going by guidelines which are now, we don't know how the environment is going to be a few weeks from now. A month and a half is what we believe will be the time that we come for potential surgery. This is going to be major surgery. There are 2 sites involved here. The liver taking precedence because that decides his survival prognosis. And of course, the primary there is too. So going by the liver, we have a HPV surgeon with us, and he's going to assess this along with us with the imaging at post 4 weeks, post 4 cycles.
So I think we lost Dr. Sobiraj in between. So he's already mentioned that this patient has actually gone in for a neoadjuvant chemotherapy and is waiting for a definitive surgical procedures. And of course, they had multiple options there, whether to do a stenting or surgery or stoma. And I think most of it has already been covered by Dr. Anil here. And so if there's anything to add in this, Dr. Anil, your inputs on this, since Dr. Soviraj is not online right now.
Yeah, back.
Oh, you're back. Okay. Good to
have you.
Yes,
sorry,
back.
We've had all kinds of problems here.
No, that's okay.
So,
please carry on.
Liver taking precedence. The liver is going to be the one that's deciding. So, assuming that he is fit for a synchronous resection, we're going to do, without any question right now, an open procedure. The liver first, and then the resection of the primary tumor. And that is what is in our minds. But we are in constant consultation and counseling with the family that what the status post 4 cycles is going to really decide. And this is the conundrum that we have. We're trying to maintain a close contact with the MDT and the family. So that, I believe, is our strength, because the future is uncertain, but all the engineering, all the protocols, all the PPE are going to be in place. Definitely not minimal access for this patient. And that's how it's going to be, hopefully, for this patient. We really can't delay it. There's one more issue. There's no real viable alternative. A young patient with an aggressive disease, advanced stage, pushing another few cycles of chemotherapy to push the surgery down a few weeks, we don't believe is an option, because that compromises liver outcomes in terms of liver function and perioperative mortality, morbidity and mortality. So we're going to take a call and go in and be prepared for surgery post 4 cycles. This is, of course, tempered with the risk of elective surgery with COVID positivity, with poor outcomes. But, like I said, it's an intense situation and we really have to plan ahead. Yes.
Please go on, Dr.
Yeah, I think as far as the guidelines is concerned, maybe you can switch to the slides. I think it's common, for colon and rectum largely. I think my bias is to go with the American College of Surgeons, and what they've done is they've placed it to context. Depends which stage your city, your hospital is in. If you are in a florid phase 3 situation, you really have to take up only emergencies. The ones that Anil Hero has highlighted: obstruction, perforation, bleeding that requires transfusions, or any of these which are impending, you have to take them up. anything that can be deferred for 3 months, like polyp or polyposis, please do that. But if your survival or quality of life is compromised, see if you have a viable alternative like neoadjuvant chemotherapy or chemoradiation therapy. Take that up, push that as much as possible. But then again, as soon as survival or quality of life is impaired and nothing else is an option, you will have to commit to surgery and be prepared for it. Yes, courage is important here, but I think planning ahead, I think, is going to be key. That's how I would summarize it. Your context of your hospital, your city, and how much risk you're willing to take. I think you really can't push anything beyond 2 to 3 months with malignancy, especially if it is advanced. You would be compromising prognosis. And please document, counsel. That I think is your best protection.
Thank you, Suviraj. Very well summarized. And yeah, so I think we've covered colorectal very well. Let's just go to Dr. Selva Sekar for peritoneal surface malignancy, summary guidelines, and what he intends doing, particularly for cytoreductive treatments and HIPEC treatments. Dr. Selva Sekar, please.
Thank you very much. As has been alluded already, we are changing what we are doing nowadays in all aspects of surgery. If you look at peritoneal surface malignancy as such, which basically includes, from the surgical perspective, pseudomyxoma peritoni, peritoneal metastasis, mainly of colorectal origin, but also there are other indications, including ovarian cancer. The standard treatment in suitable patients in the pre-COVID era, when it is a PCI score of less than 20, who have gone through the multidisciplinary meeting, would be a cytoreductive surgery and heated intraperitoneal chemotherapy. But since the onset of the COVID, like most things, the strategies have changed. The role of HIPEC in general in peritoneal metastasis is, in all cancers, you can add it up to about 5 to maximum of about 10% advantage. The main benefit is due to the cytoreductive surgery. So at the Christie, we have stopped offering HIPEC. It is because the benefit is, yes, there, but at the same time, the risks if the patient develops COVID, as I alluded to earlier, is very high. There's a 25% mortality. Is that a risk which we should take in the current context? So we have stopped HIPEC at the moment. So looking at this pseudomyxoma peritoni, where it's a very slow-growing tumor, they are all classed under priority 3, which is basically waiting for 3 months, although there are young patients who would clearly benefit from surgery, but because that is where the role of HIPEC is well proven, so we are holding them back for about 3 months. And this is all explained to the patient. It is all gone through the MDT. And as a matter of fact, we have a deviation from normal form, which we completed each MDT, where we put in that the standard practice in these patients would be a cytoreductive surgery and HIPEC, whereas now in the current context, we are delaying them by 3 months, but in peritoneal metastasis, we are offering cytoreductive surgery. So that is the way things have evolved, and more use of non-surgical options. Someone who has got a peritoneal metastasis, whom we think that the PCI score is around 20, with colorectal cancer, in the past, we would probably take them for surgery, offer cytoreduction, or as we all know, there's a 10% chance that these patients have more disease than what the scans have shown. These patients now are put on a low-dose chemotherapy so that they hopefully, which means that things would be stable. And we also, as already been brought up, we don't know where we will be in 3 months, but as surgeons, we are very optimistic that in 3 months' time, hopefully things will be back to near normal, in which case we can reassess and take these patients back for surgery. So in conclusion, there's no HIPEC being done in UK at the moment in all the centers, as far as I'm aware. And pseudomyxoma peritoni, as it is classed as a priority 3, we are putting them on hold with full informed patient consent. And we are offering cytoreductive surgery only for those with peritoneal mets of colorectal origin, usually with a PCI score of around 10. And this is a patient's scan who we can see that there is a big mucinous deposit in the abdomen, which was diagnosed as a pseudomyxoma peritoni coming from the appendix, which was treated with cytoreductive surgery and HIPEC in the pre-COVID era. If the same patient comes in now, we would watch and wait unless the patient is symptomatic, in which case we might need to consider debulking surgery, reduce the mucin burden, and review based on the stage at which the patient is after once we have a stabilization of the COVID pandemic. Next slide, please. So this is a patient with widespread mucinous deposit with plaques of disease. If it is a young patient in the pre-COVID era, we would attempt to do some form of surgical intervention. Certainly not nowadays. We would offer supportive care. And in selected group of patients, there is a role for MCAP chemotherapy. We would, depending upon the discussion with the oncologist, we would refer these patients as appropriate. Otherwise, in the current climate, it would be more of a supportive care. Next slide, please. And this is a similar sort of picture where advanced disease, as you can see, there is mucinous deposits around the liver, spleen, and there is mucinous deposits in the mesentery, which is a bad prognostic sign. And these patients, one would normally, even in the pre-COVID era, would offer a surgery just to improve the quality of life. So these would be taken with a very strict criteria of what we are, the end result is going to be. And most of these patients nowadays would just have supportive treatment. Next slide, please. This is a patient where, as has been pointed out in the slide, has got a couple of deposits. This is a patient who has had a previous cytoreductive surgery, including some liver resection with the recurrence. And these patients at the moment are being managed with non-surgical oncological treatment, which is mainly chemotherapy based, and they're kept under close surveillance. Hopefully, once the risk to the patient, staff, and the environment is all improved, then we would reconsider and get back to what our standard practice used to be. And this is a similar sort of a picture where there is, go back please, yeah, thank you. Shows a few hotspots on the PET scan, ideally suitable for a cytoreduction and a HIPEC. But as I mentioned earlier, the role of HIPEC in peritoneal metastasis is limited. It is about, survival rate is about 5 to 10% maximum, but the risks are very high in the current climate. So we would offer the standard cytoreductive surgery, which is where the benefit is in these patients with peritoneal metastasis. Next slide, please. This is a patient with a CT showing a locally advanced cecal cancer. There is stranding in the pericolic region, but it looks like there is not much of a lumen left. Any lesion proximal to the splenic flexure, this role of stenting is very difficult. And as has already been mentioned, if you're going to stent, it needs to be done in an environment where the team, the radiologist or the surgeon, whoever is doing it, is competent or proficient in doing this, in which case, so that there is not much time spent. This is, whereas if it is any cancer which is proximal to the splenic flexure, stoma is the best option. And here we discussed the options, and we offered radical right hemicolectomy. And then the question about the anastomosis comes in. We all know that even in safe hands, there's about a 3 to 5% chance of an anastomotic leak, which normally would be managed in the critical care, redo surgery, rescue these patients. But nowadays we have to be mindful of the fact that the critical care access is not that easy, especially if you're in a COVID-free or COVID-rich environment. So in this patient, we offered a radical right hemicolectomy, but there was thinking about, if it is an elderly patient, we would have done a radical right hemicolectomy, possibly plus or minus, just without an anastomosis or stoma. But this patient had an anastomosis, unfortunately has been fine. We all get a fair share of our own complications. So We can't exclude that even in the best hands, an anastomosis will always leak once in a while. So we have to have a backup plan. So the thinking in general, if you can do an anastomosis safely, please do it. But I always think about a stoma because it can always be reversed at a later date. Next slide, please. I think this is where the role of stenting is, as shown in this barium enema picture. There's a sigmoid cancer which is obstructing but not fully obstructed, and this patient was can be easily stented in the current climate and then reassessed. Obviously, we all know that the stenting is not the best option, but we have to. We are in a different environment, and that is the way we are working because the strategy is different. Next slide, please. And this is a patient who has had a stent in. I think the main thing about the stent is if it is a centralized service, if it is a good environment, if it is a team which is used to this on a regular basis, then we should just opt for discuss with them and then refer this patient so that the stent can be done. This is not the time where teams can try out whether stenting can be done, and if it fails, go on to a stoma, because that exposes the whole healthcare professionals to a huge amount of risk. Next slide, please. So this is what now we are talking about in UK, because I think people were expecting a spike, same as what has happened in Italy, but fortunately it does not happen. It is more of a plateau. As a matter of fact, we have regular meetings. In London was unfortunately took a big toll with a lot of COVID cases. But now things have stabilized, but there is, instead of a peak, it looks like it is going to be a long drawn plateau, which means that it is going to affect the way we work, affect the patient care, affect most of our regular routine life for few months, possibly for the rest of our life, who knows. Certainly till the vaccine is out, whatever these lockdowns are all temporizing measures. We may have another spike or a couple of spikes, no one knows, but everyone is planning for a recovery. Basically, the admissions to A&E, the consultations to the outpatients have reduced because patients are frightened, patients don't want to come in. So, but the cancers, they don't wait. I'm sure the people are sitting around in the community with cancers, but they don't want to come to the hospital because they're worried that if they come to the hospital, they will catch COVID and die. Which is why some people feel that the treatment now is worse than the disease. But at the same time, as healthcare professionals, we have to be mindful that we have to always be careful about the harm which we can do in the current climate, and also look at the reduction in the critical care capacity, which to some extent has been mitigated because there is reasonable capacity in the critical care at the moment. So working as a team, we should start every healthcare institution should start having a plan for how and they're going to address. It's not going to be the same. So our protection, the social distancing, everything has to be taken into context. Certainly the efficiency is going to be low. What we may be able to achieve in one theatre list may not be able to be done because we have to be cognizant of the anesthetic time, the footfall, the reduced theatre personnel available at the time of surgery. And as someone mentioned, PPE, we say that it's great to have, but it's extremely difficult to operate with full protection, because one of my colleagues was saying you probably get a bit of a carbon dioxide narcosis because the face mask fits so tightly that we can't operate for a prolonged period of time. So at the Christie, we have made a clear mandatory sort of principle that the whole theatre team will stop after 3 to 4 hours of operation. We won't continue beyond that. Take a break and then come back and then do, because our procedures are usually about sort of one case we do for an all day, and there's no way we could continue on for a prolonged period of time without having a bit of a rest. So it has been taken that we will stop and then have a bit of a break, and then the whole team will come back or have another team. And this is where 2 consultants operating comes in as well. Unfortunately, it's not a good time for surgical trainees, but at the same time, we have to be mindful that the patient comes first, that staff and the environment in which we work in has to be looked at, and then the surgical training, which we can always address. There's plenty of time. And that's what I would like to say. Thank you very much.
Thank you, Dr. Selvasekar. So what we're going to do is I'll just have 2 or 3 slides just on the take-home messages, and I'll take the final word from all the panelists. They can just give one final line or one final word for everyone as a take-home message. So just the last couple of slides. This is again taken from the guidelines. The urgency of operation needs to be proposed, that most hospital systems are endorsing it, that hospital resources, even only if they allow, should a surgical procedure be done. If we can delay surgery for a curative resection for 3 months, please do that. Otherwise, and put them on neoadjuvant, or otherwise opt for a surgical option. Test these patients good. Test these patients like has been mentioned several times. It's absolutely paramount. Consenting needs to be done. Documentation needs to be done. Open surgery rather than minimally invasive. You need to see whether your ICUs are functional, your ICUs are not having COVID patients. They should be completely separate ICUs, HDUs. The length of the recovery has to be seen so that these patients can be discharged early. Cancer surgery should be, or all surgeries should be simple, short, with minimize the morbidity, minimize the blood loss, prioritize your surgery, which we've discussed already. Avoid surgery where there are doubtful benefits of other procedures or other modalities of treatment like neoadjuvant chemoradiation. Avoid excessive surgical time, minimize the number of people who are there in the OR. Then some of the points I just noted, which all the panelists have mentioned over and over again. The green zone, as mentioned by Dr. Selva Sekar, hub and spoke model. He spoke of that, and which makes sense. MDT and documentation, Dr. Suviraj mentioned several times, whether the MDT is a virtual one, but do it. Documentation, extremely important. Dr. Rajesh mentioned quarantining the patient 7 days prior to surgery, extensive testing of COVID-19, doing both the RT-PCR and the antibody testing. Open rather than laparoscopy, mentioned by Dr. Kriplani and all the other panelists. Wearing PPE, I can assure you, I've used it. It's a terrible experience wearing those PPE and operating, but at the same time, the precautions need to be taken. Dr. John mentioned early discharge, decrease the A loss. Dr. Selvaraj mentioned that decrease the less of anastomosis, more of stomas. That's what mentioned by Dr. Anil Haroor as well, though he said that he did the anastomosis, but he would rather opt to do, in most cases, stomas rather than anastomosis, decrease the follow-up of these patients. But all this with the caveat, which all the panelists have mentioned, is that the pandemic is a dynamic process. Things are changing. We need to change our strategies and keep discussing again and again. With this, I would like one single line from all of you panelists, starting from Dr. Kriplani, sir, first.
As I said earlier, Randeep, that we are all these recommendations are presuming that the COVID is not going to last for more than 3 months, and it doesn't seem to be the scenario. So every time we have to constantly keep on revising the recommendations, and beside these recommendations, we have to see their adaptability in our local environment, in our hospital, in our society, the cost implications, and the outcome measures in delaying these surgeries for more than 3 months. So all these things have to be kept in mind. But one thing remains, that in malignancy, multidisciplinary approach and multidisciplinary opinions should be sought more often, even if it is a clear-cut situation, if it was in a non-COVID patient, and it should be documented. Teleconsultations should be encouraged as much as possible to decrease visits of the patient to the hospital and to decrease the physical proximity between the caregiver and the caretaker.
Thank you, sir. Dr. John Thana Kumar, your take-home message, apart from whatever we've discussed. Dr. John, you need to unmute yourself, please.
Okay. My one-word advice will be, take-home message will be, discharge a patient very early, unlike in open times, and leave your drains there. Discharge a patient with the drains if necessary. Be generous about draining, unlike in standard surgery. Over to you.
Dr. Rajesh Bhojwani.
Yeah, if you allow me, I'll make maybe just 2 or 3 lines rather than a single line.
Please go ahead.
Lot of, and I've been operating some cancers in the last 1 week. Initial few with the PPE, then gave up the standard PPE. As all of you have mentioned, it's not very easy. I operated a CA rectum, which was perforated. I did it on an open patient with 36 BMI lady. It was not easy with the PPE. Eventually, I understand, because we are all minimal access surgeons, the choice of procedure will depend upon your own comfort and habits. To me, I would still prefer to do a rectum and esophagus with minimal access and everything else with open, because I believe strongly that the open does not give you an inferior outcome for the patient, long-term outcome. Some few differences in the Indian settings. Dr. Selva Sekar mentioned a preference of stoma, even for the right colon. Indian settings, stoma takes a longer time for recovery. It is more expensive, and we don't have an NHS-like beautiful facility which can cater to the needs of the patients. So we keep a less threshold for stoma, where there are no risk factors. And I would rather prefer to do an anastomosis if there is no risk, leak rate is less than 1%. In the era of eras, most of these patients will go home on day 3 or day 4. In our settings, obstructed left colon cancers or rectal cancers, stents come handy. Our endoscopists, they can usually tell us beforehand, based on the imaging, whether the stent will be good or not. And I am not sure if wearing a PPE and taking a break is an option. We have the scarcity of PPEs. And before making the last comment, we have several guidelines in place. I tried to go through all the guidelines, but believe me, I could not make much of messages out. Guidelines are as confused as all of us are at the moment, and it's basically the dynamic situation which is keeping everybody confused. And I would say 3 things will make us decide every individual outcome. The patient safety and outcome is paramount. For the first time, we have realized that the safety of the staff is also paramount. As surgeons, we should not make decisions based only on our outcomes and preferences. Remember, there's an anesthesia team which is going to get exposed. And based on that, I think modality of operation, perhaps based on all these things, is the least important factor.
Thank you, Dr. Rajesh. Dr. Anil, for your concluding comments, please.
Thank you, Dr. Randeep. I think I would echo Dr. Rajesh Bhojwani's sentiments that basically, I think more than guidelines, it is pure common sense. It is an awareness of an evolving situation. We are used to doing things in a very fast way as surgeons. So I think we have to take time. We have to go step by step procedure in each procedure. For example, the donning and doffing of masks and PPE kits is something that everybody should study. Take some time, allow the team to get accustomed to this new normal. Secondly, I don't think we should deny non-COVID patients the right treatment. The treatment for them is as important as a lot of people have mentioned. We don't know how long this epidemic is going to go on. Third thing is about stomas. I mentioned stomas in the situation of obstruction. As far as routine cases are concerned, I would agree with Dr. Bhojwani that we will go ahead and prefer an anastomosis. A stoma is difficult to manage, and remember, even the GI is going to concentrate virus. So if you have stoma, then it will create a problem as far as managing the stoma is concerned. So if it is not obstructed, I would still prefer to go ahead with the anastomosis. And I think most importantly, let's have the safety of all our staff in mind, because once the staff gets isolated, then your whole hospital is going to get shut down. They are the backbone. We have to take care of each and every one of them. So stay safe and use a lot of common sense.
Thank you, Dr. Anil. Dr. Suviraj, your final comments, please.
Thank you, Randeep. I think most points are well covered. I would like to stress on the OT protocol and practice, because this, I believe, is going to be the rate limiting factor. for the subset of younger patients with aggressive disease, irrespective of site, they are going to require surgery-intensive procedures. The PP is highly uncomfortable. I believe we as interventionists have to check out the PP set, the options, whether it's a half-face mask with a filters with an exhalation valve or a full-face mask. Please check all these options out. Your comfort and the team's comfort is going to determine the safety and the efficacy of the operation, not just the patient, but also to you and your team. Because there are patients who are going to require aggressive therapy, and we really can't back out of it, both time-wise or by intervention. So all of us don't have the luxury of negative pressure, ventilation in our OTs, or suction devices with filtration. You're going to have to plan in advance, purchase it if you can, innovate otherwise, or compensate by protocol, like have at least 10 or 12 exchanges of the air before you step in after intubation. You're going to have to plan aggressively ahead to innovate. Otherwise, patients are going to suffer, and most importantly, your teams are going to suffer. Plan in advance, your OT practice.
Thank you, Soviraj. And Dr. Selva Sekar, your take-home message.
Thanks very much. I think a lot of the surgical side has been covered. And when we had the first meeting with the IAGES, Raman Goyal and his team, one of the things they wanted assistance was in audit or sort of working collaborative. I think this is a fantastic opportunity where, if possible, I don't think you will be able to get all the cases which are being done in all centers, but those who are doing surgery in this COVID environment, if there is a way to audit that, capture all the cases, whoever wants to contribute, it can be as allowed as an opt-in option if people want to contribute, then you will be able to get an outcome, because as we all agree that this is going to last for some time. So to get some ground rules on ground based on evidence, at the moment, there's no evidence. We are talking about people making the decisions based on what they think is right. Whereas I think the time is there now to capture what has been done and audit the results, which will allow the practice in India to mature with time. So I think a fundamental thing would be my suggestion, my take-home message would be, if it is possible, IAGES can take a role in auditing the outcomes of the surgeries which is being done in the current context. And also the second thing is India is known for innovation. And this is probably an appropriate time for these low-cost innovations in not just the suction side of things, in the whole package of surgical armamentarium, which I think it provides a good opportunity. And with a good quality assurance, I think the IAGES can be a leader in allowing these sort of projects to mature with time with a good proposal. And we can probably collaborate with ALS-GBI and come up with ways to produce these low-cost innovations. Thank you very much. Thanks for giving me this opportunity.
Thank you, Dr. Selva Sekar. Good you use the word innovation and not jugaad. No jugaad works for COVID-19. So we want to avoid that word jugaad. But yeah, at the end, I'd like to thank all my esteemed panelists. You have given excellent inputs. And so thank you very much for joining in. I also particularly want to thank Dr. Rajesh Bhojwani, who gave me the idea how do we conduct this this webinar so that just make it more interesting rather than just theory. And we added case capsules to that. Thank you for that. And we were supposed to do it for an hour. We've been actually discussing for 2.5 hours. So that itself shows we've done a good job. I want to thank Dr. Raman Goyal, President of IAGES, and the team IAGES for organizing this webinar. And also want to thank Asavari and Lab Guru for giving us the platform. So thank you very much. And we can sign off now.
Thank you so much, Dr. Vadhavan sir, and all the eminent panelists. Thank you so much for your time. It has been really a wonderful discussion. And I'm sure Lab Guru viewers have enjoyed this session a lot. Thank you so much.
Thank you.
Thank you.